specific indications, and I think one of them is, lentigo maligna, right, on the face. And just for clarification, lentigo maligna is a type of melanoma in situ, mostly localized on the face or sun-damaged skin. Surgery usually the option, but sometimes the patient is too frail or the tumor is too large that we needed some other modality to treat. And why don't we talk about that first and the efficacy of radiation for treating lentigo maligna?
Yeah, I mean, this is, another one of these topics that, some of the earliest reports that I've found on using, methods of radiation therapy, which we wouldn't use these days, but, were certainly standard at the time in the 1940s, 1950s. These early reports show quite clearly that, large facial lentigo malignas can respond to radiation therapy. By response, I mean, that pigmented area loses its pigment and appears to normalize. Over the years, this treatment has been used selectively. What I mean by that is that patients are primarily chosen for this on the basis of the extent of the lentigo maligna, how large it is, and whether, they're suitable candidates for other treatments. As you as a surgeon know, typically surgery is considered the best treatment for lentigo maligna. In my view, that's because number one, it removes the condition, the neoplasm, and number two, it tells us, it gives us information about what's actually there. Other forms of treatment, generally, including radiation therapy, don't tell us additional information about the lentigo maligna. But as I was saying, patients that were selected for radiation therapy, they often weren't good candidates for surgery.
Sure.
The lentigo maligna was too large, too extensive to remove with surgery. Perhaps they were elderly, weren't medically fit enough to undergo a large surgical procedure. And so historically, reports on the use of radiation therapy for lentigo maligna involve, patients that just weren't good candidates for other treatments. And there's a wide range of experiences that have been published about this, the efficacy of this. Some of the larger series are from Europe and suggest that, between 80 and 90% of the time, radiation can control lentigo maligna. But, bear in mind that these were in patients that were selected specifically for this treatment. So that introduces some bias, and we have to kind of keep that in mind as we interpret those, research studies.
So Chris, let's say, a patient of mine, and I deemed that she or he is not a candidate for surgery. I send that patient to you, right?
Mm-hmm.
How would you consult that patient? What's the process? What would you tell them?
So, I would basically discuss what we know and what we don't know about using radiation for lentigo maligna. I would indicate exactly what I just mentioned. That is, this has been done before. Doctors have looked at the efficacy of this and shown that, 80 to 90% of the time, radiation seems to produce a response in a lentigo maligna, seems to control it. And some of the caveats are that, generally patients are selected for this treatment on the basis of being ineligible for surgery. And most often this happens because patients are elderly. As this happens in people that are older. And what tends to happen in older patients is that we don't follow them for as long. So the long-term success of radiation therapy for lentigo maligna is not something that's entirely clear. And again, primarily this is because patients that are selected for this are elderly, and we just don't have long follow-ups with them.
So before we even get to the prognosis and follow-up, but like in terms of, can you walk us through the logistics, like how frequently and what modality you're using? And
yeah,
so let's go through that first.
Yeah, so generally speaking, I would use an external beam radiation therapy approach for somebody with lentigo maligna. As you know, these tend to be very, very superficial neoplasms.
Sure.
And I emphasize the word neoplasm here because lentigo maligna, as you know, is not an invasive melanoma. It doesn't have metastatic potential. And so this is really a pre-malignant condition. And I always emphasize that to the patients because often, people hear melanoma and it provokes a lot of anxiety.
Sure.
And really being clear that, lentigo maligna is not invasive melanoma. These are very different entities in terms of their behavior, their natural history. But again, because this is a superficial skin neoplasm, we can often use superficial forms of external beam radiation therapy. In fact, the Europeans have largely used something called Grenz ray therapy, which involves ionizing radiation that's kind of the lowest energy ionizing radiation that we have available. I haven't used that. It can be a little tricky to use that if you don't have the necessary calibration equipment. I've generally used what's called superficial radiation therapy, around 100 kV energy X-rays, and these penetrate very superficially, just a few millimeters under the surface of the skin, and that's sufficient. Generally, we give the radiation therapy in a series of little doses. The reason that we do this, or we fractionate the radiation, is to try and prevent side effects, both short-term and long-term. Now, this obviously is something to consider carefully in someone who is potentially limited in terms of their functional ability, their ability to come in for treatment, their life expectancy, the need for many, many, many weeks of radiation therapy may not be as great as it is for someone who's perhaps younger, has a longer life expectancy, and you really want to prevent those long-term side effects from happening.
And just on average, how
Mhm.
frequently do they have to come in, and how many those fractions are you talking about? 20 over a course of 6 weeks, or?
Yeah, so typically for lentigo maligna, the regimen that I've used is around 20 to 25 treatments over 4 to 5 weeks. However, shorter courses or fewer treatments can be considered, perhaps as few as 5 treatments over a span of 2 to 3 weeks can be used. And again, that decision is primarily based on one's life expectancy and a patient's ability to come in for these treatments, and of course their perspective on long-term side effects.
So the bottom line is, let's say if you can fractionate this longer, meaning you give smaller dose and do a longer period of time, and you will have, theoretically less of side effects, right? But if most of the time, but you have to meet the logistics, because patients sometimes may not have the transportation or caregivers availability, sort of taking them every day to the centers. And
Yeah.
those treatments are relatively quick, isn't it? Like when the consultation process is a little bit long because you have to explain it on the first time. But once you set up this, and when they come in, it's how long usually take? 10 minutes or so per each visit?
Yeah, I mean, the treatment visits do tend to be brief, anywhere from 30 minutes to an hour. Most of that time, is spent us getting the machinery all
Sure.
set up and ready for the patient, getting the patient, into the position they need to be in for treatment. We're double checking, we're triple checking. Once everything looks perfect, then the radiation machine turns on and the beam of radiation is delivered. And that delivery of the radiation is brief. I mean, 2 to 3 minutes usually, depending on the amount of radiation given. Patients don't feel anything during the radiation. You hear the machine make some noise, but it's not as though you can feel the radiation being delivered with each treatment. And generally speaking, they feel the same way when they leave the department from their treatment as they did when they walked in.
And the most important thing is when they lie there during the 2 to 4 minutes when the radiation is actually, they're getting the exposure, they shouldn't be moving around. They should just sit still. That's perhaps the most important thing. I guess your staff will remind them.
Yeah, and there's ways that we can ensure that the radiation is being delivered accurately. In some situations, we'll actually create devices that help keep the patients still and in the same position for treatment. That's not always necessary. To some degree, it depends how the radiation is being given, where the radiation is being given, and the patient's abilities as well.
So, and what should they expect? I mean, at what point do they see the erythema, the sunburn-like reaction, and what percentage of patient will actually get this kind of a like desquamation and peeling, and also what kind of aftercare that you give to your patient?
Yeah, so usually around 2 or 3 weeks after radiation therapy starts, you begin to notice the inflammatory effects of the radiation in the skin that usually manifests as the skin getting pink and then getting red. It could become itchy, it could become sore. It's like having a bad sunburn, basically. And I would say that most patients having radiation therapy for cancer of the skin can expect to experience this.
Sure.
Um, and the good news is it's like a sunburn in that it's temporary. A few weeks after the radiation therapy is finished, this inflammatory effect on the skin starts to resolve. Now, again, you asked what fraction of patients experience this. Almost all will experience, erythema or redness of the skin. The desquamation or peeling of the skin, not everyone experiences. To some degree, this depends how large an area is being treated, whether this area of skin has been previously exposed to the sun, has been sun damaged or not. There's some things that we can do to try and help, take care of the skin during treatment. Topical emollients, moisturizing creams, sometimes topical steroid medicines, things like cortisone. They can reduce some of the inflammation in the skin and make it recover a little faster. Sometimes if there is peeling of the skin, we'll recommend things to kind of help prevent infection, help the skin heal. But again, generally that process starts 2 or 3 weeks after the radiation's finished. And we're seeing our patients after treatment to check in, make sure that healing process is going along as expected. And in most cases, it is. It's unusual to have like prolonged dermatitis or inflammation of the skin, more than a month or so after treatment finishes.
Especially if you sort of fractionate this, like really, really like numerous fractions instead of delivering it really quickly, basically. So what kind of you just basically after the radiation, you just basically telling people to put on some sort of moisturizer, lotions or creams and over the area and keep it moist. Is that the only instruction you give, pretty much?
Well, the moisturizers are helpful because the radiation can make the skin dry. Skin dryness in and of itself is usually not a terrible problem. And depending on the part of the body, for example, the nose it's pretty rare for the skin to get
Sure.
dry. It's quite oily. But if the skin gets dry, what can happen is it can become itchy. And if it's itchy and we scratch it, that can lead to infection. And certainly having a skin infection in the area that you're having radiation therapy would not be a good idea. So we try and prevent itching from skin dryness by using a moisturizer. As I mentioned, the radiation therapy can produce inflammation of the skin, that redness, and that can cause itching as well. So for similar reasons, we'll use an anti-inflammatory medicine like a steroid ointment to help curb some of the itching. The steroid ointments are quite good at doing that, really to try and prevent scratching of the skin in the area where the radiation is. And then, after that, in terms of the progression of the effects of the radiation on the skin, we're largely looking at, the barrier functions of the skin. If the skin starts to peel and lose its barrier functions, it could lead to infection in the skin. And so we're primarily focused on,
Barrier
using,
repair and
yeah, things that can kind of, keep the barrier intact, prevent infection from happening, monitoring for infection, all those sorts of things. And again, with time, provided that the right amount of radiation has been given and not too much, the healing process usually kicks in around 2 or 3 weeks after the radiation is done, and patients are starting to feel better at that point.
that's good to know. That's a good time frame for folks to know.